So today I have the pleasure of speaking with a good friend of mine, Rob Volpe. Rob has been a paramedic for just over a decade, correct?
That's 13 years.
13 years, incredible. And you're currently working as a primary care paramedic in York, so in Ontario. And
That's right.
before that, you worked in multiple other provinces, territories, including Newfoundland, Nunavut, and where we had the pleasure of meeting in Nova Scotia. And working in those different services, you've occupied several different roles. So you've had a very eclectic paramedic career, which is exactly why I wanted to speak to you today, because typically, historically, paramedics have been, or the profession has been known as one that there aren't a lot of opportunities. You graduate, you work on an ambulance, perhaps you can go into management roles after. For example, as compared to other healthcare professions like nursing, where there's a lot of different avenues you can go by, but that hasn't been your experience. So I'd love to hear more about it, your journey and what you've done.
Truthfully, thanks, Matt. That was very kind. Truthfully, that is when I entered this profession. My perception was that it was a very linear role. So you do ambulance-based work, and like you said, maybe advance into some kind of management role or whatever. That has not been my experience. So I've been fortunate in my paramedic career to do a few different jobs. So I went to college in Ontario. It was a 4-semester, 2-year college-based program. And upon graduating, I left my home province to work full-time. So I started my career in Newfoundland, and I worked there for a year. That was a very eye-opening experience. I was the first paramedic to actually work in my small community. They had just had first responders managing the ambulance service, so it was kind of interesting to get your feet wet as a paramedic, kind of by yourself or with like the support of colleagues who were perhaps less academically trained or whatever.
Yeah, interesting. And how was that?
Yeah.
How was that being away from home, being away from friends and family?
Yeah, it's interesting that you're not just touching on the profession, but it was challenging to be by myself. I was in a area of the world where most Newfoundlanders, for example, would immigrate to more populated provinces for work, and I was doing the reverse. So it was interesting being, foreign to the community. It was interesting trying to figure out how to become a paramedic without other paramedic role models. And then being so, like, I was on an island, so being isolated from friends and family was also a bit of a challenge.
Of course, very unique experience. And then from Newfoundland, where'd you go after that?
Well, then I moved. So if I can, I kind of a funny story. My parents came to visit me. They flew out, and it was July 1st, actually, in 2010. And believe it or not, there was actually snow. It was snowing during the Canada Day parade while my parents were visiting me in Newfoundland. Anyway, they visited me, and I had a dog at the time, and I said, "Hey, do you mind? I'm resigning my position. I'm going to take a leave and move back to Ontario." And I said, "Do you mind taking the dog with you on the plane so that when I drive back, it will be less burdensome on me?" So they did. They took the dog with them, and they went home to Ontario. And while I was driving, while I was driving back to Ontario, I left my job and whatever. I actually got a job offer in Nova Scotia. So I did not make it back to Ontario. I stopped. That's it. I stopped in Nova Scotia, and for 10 more years, that dog lived with my parents. So.
Did you ever get the dog back, or?
No, I never got the dog back. Well, that's another story for another time. But my mom was formed an attachment.
Okay.
So I left the dog with her, and she was happy to do that. But I never made it back to Ontario. I got a job in Nova Scotia as an ambulance-based paramedic, and that's where I started my Nova Scotia journey. That's where I met you, working the truck. So
Great. And so, yeah, so you said ambulance based. I happen to know you had another role there, specifically in Nova Scotia at what we call the CEC. Obviously, you can fill us in about what that stands for and what the role was.
yeah, for sure. So I started as an ambulance-based paramedic, and then in the rural areas of Nova Scotia, they started to become challenging to staff physicians. So there was a real risk of closing emergency departments, again in rural areas. So what they did is they piloted a project where they would pair an RN and a paramedic in the emerge, and they would have several emergency departments with this kind of staffing model. And it was generally through the evening hours, and they would have one physician available to all sites. So if and when a patient came in through emerge, they would receive an assessment from the RN and paramedic team. There would then be a collaborative consultation with the physician, and the three practitioners would make a determination on a treatment plan.
Mm-hmm.
Whether that was to move that patient out to a tertiary or a higher level of care hospital, or perhaps they required something like IV antibiotics or whatever. That decision was made as a team and implemented, so the physician's presence wasn't actually needed, just their consultation. And so that program, I think, in effect, saved the closure of a multitude of emergency departments across rural Nova Scotia. They called it, collaborative emergency center.
Yeah, exactly. And have you kept an ear? Do you know, because this is over 10 years ago, obviously, since we were there, or approaching that anyways, do you know if they're still open? I'm assuming the advancements have just been incredible there as well, compared to, again, where they were at before, and now we're a decade later.
Yeah, well, it's funny you said it has been a decade later. It's crazy to think that. As far as I know, they are still operating, and I know that in other jurisdictions across the country, they are implementing similar programs. They're starting to hire paramedics more in hospital settings, and it's even more to the forefront as of late, because there are healthcare provider challenges, like staffing challenges,
Of course.
As a result, as a ripple effect of the pandemic. So,
of course,
I have heard.
If you recall my experience there, I was part of a pilot project as an emergency department transition zone. From my understanding, that's not still going on. I think they're looking at something very similar here actually now.
Right.
Where essentially we would coordinate ambulances coming in, and then the patient would have a specific pathway, either coming, staying with us in the transition zone, where I would be paired up also with an RN. We would triage the ambulances coming in, so they'd come with us, go to the waiting room, and or maybe go into the resuscitation room, or straight to a bed in the ER, or stay with the paramedics to kind of free up the ambulances to be able to respond. But at the end of the day, it's a whole flow through problem through the hospital, and of course sometimes they would come to the transition zone and get treated and released directly from us, but other times it was essentially a band-aid to kind of a system-wide issue. But it was a really unique experience, just seeing the advanced care paramedics there working in certain departments where they were doing suture and casting, seeing other paramedics doing triage. It was a great experience, just to really open my eyes to, wow, the paramedic can have so many different roles in the healthcare system.
Yeah, absolutely. It's and it is a bit dated now, because Nova Scotia's been doing it for such a long time. But I hesitate to use the word innovative because it's been happening for so long. But advanced care paramedics working in emerge, and primary care paramedics working in emerge, it just makes sense. It's I would suggest that it's a lot of politics as to why it's not happening in other jurisdictions more, but but I think it's a good model of care.
Of course, I mean, just by the nature of our job and our training, I mean, we're especially, and you corrected me before calling it out of hospital care, to be up with the modern lingo, but essentially providing care in uncontrolled environments. So being able to adapt to whatever reality we're faced with, it makes sense that we'd be a great solution. Paramedics would be a great solution to fill the gaps in other roles that in the healthcare system.
Right. I agree. I
So,
agree.
and then from there, so you did work up north as well?
So there was a time, Matt, and to whoever's watching this video, that I worked 3 jobs at the same time in 3 different provinces. So I worked as a paramedic in Nova Scotia in both ambulance-based and emerge-based settings. And then I also worked in Summerside in Prince Edward Island.
Prince Edward.
I worked as an ECG technician.
Okay.
Which was an interesting role. So it was an office-based job. It was an office-based job where we would remotely monitor mobile cardiac telemetry devices. So someone would go home with like a small device that they would wear around their neck. It was an ECG basically that was connected to cell phone towers. So we would in real time monitor their heart rhythms at home. And if they had a problem, they would push a button, and then we could call them and we could talk about it. So if they started to feel lightheaded, for example, we could pair up their sensation of lightheadedness with an arrhythmia in real time. And perhaps maybe they were having a chest pain. So we could flag that, and we could activate, emergency services in their local area as a result of the real-time monitoring.
And did you have to do any additional training, or just your background as a paramedic automatically got you hired, and then maybe the in-house training?
Yeah. So I didn't have to go to school or do like a college diploma or a certification in that sense. That the being a licensed paramedic was sufficient. However, there was a lot of continuing education. We had a cardiologist on the team. We would always be talking about and dissecting ECGs. It was a very collaborative team, and you're again, as I mentioned, as office based, so you had teammates there, and so you could easily consult with your colleagues. It was interesting.
That's something that would even, I guess, again, we would not even think of would be a possibility or a possible role as a paramedic. So that's really
right. Yeah,
helping your interpretation skills. That's for sure.
Yeah. Well, oh yeah, definitely. So, and I have noticed that it got rusty when I stopped being a technician.
Of course,
because you just don't see as many, as many unique ECGs on the road, right?
Yeah, exactly.
The
third.
What's that? Sorry.
The third job. That was 2 out of the 3.
Yeah, that's right. That was 2 out of 3. That's right. And then the third job I had, I worked as a flight paramedic and like a clinic-based paramedic in Nunavut in the Northwest Territories. And this job was like, as paramedic students, you will be like searching jobs and job postings, that kind of thing. And so this is an industrial paramedic, would maybe be the term that you would see if you're searching for this kind of role. But they would fly me in for 3 weeks at a time, and I would work out of a clinic. So I would have clinic hours. People would come see me for very low acuity issues like GI upset or routine fevers, headaches, that kind of thing. So those are the bulk of the patients that I saw. And then in the evening time, I would be on call. So if there was an emergency, I could respond in a more typical paramedic fashion. And then,
were you part of a team, a collaborative team, or was it just you?
Yeah, so there was a time where there was a short time where I was paired up with what do they call them in the military,
Like a med tech?
med tech, yeah. So he and I worked collaboratively together, but most of the time I was solo, and then I had a physician available by phone.
Okay.
So if I did require or email even. So for some of these low acuity issues, we could email back and forth about a possible treatment plan.
Okay.
If clients required evac, that was my role as well. So I would fly them out to wherever they needed to go for a higher level of care.
Great. And out of all those different roles, was there one that you preferred? Did you prefer clinic-based, ambulance-based? Obviously, you're doing ambulance-based now, but
I'm doing ambulance-based now only because the role working for a clinic, you're working in the private sector, so it's very contract heavy. So less so about the profession and the role, but more so about the practicality and like the labor movement in general, right? These jobs are what we call precarious, right? You get an 8-month contract. It's great money for the 8 months, but then there's no guarantee of continued work beyond that. Whereas now I work for a municipally and provincially funded paramedic service. I know that I'm permanent full time, and then I have a job essentially until I retire. So
somebody
yeah,
potentially like at the beginning or at the end of their careers,
exactly.
I guess, semi-retirement, or again, just new students getting into the field and wanting to go on an adventure.
Exactly.
What it
Yep.
makes for.
And depending on where you work, it can always be an option. A colleague of mine, I think he's 50. He's very smart, very bright. He works with me in community paramedicine, but his career aspirations weren't being met by the role that our local like paramedic service was operating at. So he took a leave of absence and pursued this sector of the paramedic world. And he fortunately, because the employer is who it is, you will have the option of returning back. So
Yeah, that's
he
great.
gets to have a little fun. What's that, sorry?
I think that's really important to be able to do that.
Yeah.
Just like here at John Abbott, in my teaching role, we are able to take sabbaticals to go and pursue things of interest.
Right.
It just ends up benefiting everyone afterwards, So not only just the employee gets to go out and experience this and get that satisfaction out of it, but also what they can bring back from their experiences.
Absolutely. It lends some perspective too, right?
Of course.
Yeah.
Right, so you touched on it. So you said community paramedicine. So tell us more about that. How'd you get into
Sure.
that?
Yeah. So again, in my role, so I worked for a municipality in Ontario, and my full-time job is as a paramedic working on an ambulance. But frequently there are opportunities to work in different streams. So I have been an educator, an adult educator here for my service. So we do in-services.
Education.
Exactly. Yeah, exactly. Or if like a new piece of equipment is rolled out, we can provide the training on how to use it and that kind of thing. And then most recently, well, I guess for the last 6 years, on and off, I have been a community paramedic. And so we've heard this term tossed around, and it can mean a lot of things in a lot of different paramedic services, a lot of different communities, a lot of different jurisdictions, right? But for us here in York Region, there are a few things that we do. So there's like a slightly expanded scope of practice. There is a heavier integration into social services, and there was a third thing I wanted to say about it, but and then it's program based. So we like run and implement a multitude of programs. So
okay, so what would be like a couple of examples? Well, I guess maybe going back, so expanded scope, what would be an example of an expanded scope of practice?
Yeah, so there's a couple of things, maybe your students might hear this and I think it's like earth shattering. We're not, we're not putting crikes in, for example, or like, crazy medical procedures, but we're doing urinalysis, drug screening, pregnancy testing, as well as we'll do venipuncture for like blood draws and that kind of thing. And then, but these are,
Or
what's that, sorry?
any antibiotic administration or anything like that?
So there was a time where our program did do that during it was a pilot project.
Yeah.
It may again return. It's again in our jurisdiction, the program is having a kind of a rebirth.
Okay.
So we're starting small, and our team is growing. So before we had 4 community paramedics who are highly specialized and could do this kind of thing, but now we have a larger team of around 20, and you can imagine that the continuing education and maintenance of certification for some of these medications and procedures and stuff is high. So I think they're starting slow and low again.
Okay, and I was just looking up online, obviously, looking up a little bit. You participated also in an AD program. Was that still part of the community paramedicine, or is that just a completely different program?
Funny. I want to know where you found this stuff. Is my name somewhere on the internet associated with AEDs?
Of course, it is.
Okay, so I don't want to go back. I don't want to go back and forth. Oh, sorry, Matt. Go ahead.
Sorry, I was saying I also found the sunshine list, but that's another conversation.
It's a lot of overtime.
Yeah, there we go.
Oh man. So I don't mean to go back and forth, but when I was an adult educator, part of my role was also some public interface, and so we our team worked to identify all the automated external defibrillators in the region. So and then help the private owners in like a maintenance program to make sure that the monitors were running and working and accessible. So if you called 911 and you're at a community center, someone dies and is in need of an AED, and you call 911, the 911 operator will be able to dispatch paramedics, but also tell you that on the second floor behind them, next to the men's washroom, there is an automated external defibrillator. Send someone to go get it. So that was they're working really hard to shorten the time of sudden cardiac arrest to application of a defibrillator.
Wow, that's great. So essentially you had to map out and find out where every single AED is.
That's it. Yeah. So we had like a program where people could register their device, and then we had like old lists of a patchwork of programs that existed before, where we cold called everyone and reconfirmed where everything was, and so that was part of it. And then and part of it was like education for the public and those kinds of things, and CPR training for our paramedics.
Using AD, I'm assuming.
Yeah.
That's great. That's really interesting, because I'm especially recently I've taken a really big interest in not only in personal relations for paramedics, but also prevention programs. Because I think that's something that, again, historically, that we haven't necessarily been proactive at. And I think it should be a huge part. It should be a part of our role as paramedics.
Right. I'm glad you.
Prevention.
I'm glad you touched on it, because to go to our talk around community paramedicine, a lot of it is prevention. So we host and run wellness clinics in like seniors apartment buildings, for example. And these wellness clinics, the core is their blood pressure and routine checkups and that kind of thing. But we also do health coaching. So talking about healthy eating, providing resources on healthy eating, Like, for example, we can connect them with, in Ontario, you can speak to a registered dietitian for free over the phone. So connecting these folks who often are like single, perhaps cooking for one can be a bit of a challenge. And so we do try to like support healthy eating habits, that kind of thing.
Was fall prevention in there as well? Because I mean, that's
Yes,
one of one of the most frequent calls that we can get through 911.
that's right. Fall prevention. So, and again, well, this is now years ago, but it was within my role within community paramedicine. I sat on a fall prevention strategy like committee with other community partners. So, you know, like social services was in there. There was the Alzheimer's Society was participating. As all these different governmental groups as well as non-governmental, non-profit groups were part of it as well. And we came up with like a strategy booklet. So, you know, again, it's if you don't read it, you don't know the content. So you'd have to try to encourage your clients to peruse. But there's like a proper way to get up after a fall. There are safety devices that can be installed in one's home and that kind of stuff. So
Of course, well, I mean, just last Sunday, that's exactly the call that I got. Gentleman wasn't sick, but was stuck in the bathtub. And
oh yeah,
you know, again, that's almost classic, but yeah, he did not have the right equipment for somebody of his age.
right.
You know, somebody,
So let me ask you, what did you after you helped him, what did you and your service do?
for sure. So my service did not do anything in particular. I myself did speak to the gentleman, the patient, as well as his wife, to make sure that they would follow up, and specifically here's the CLSC. So they were to call the CLSC because I do know there are programs there to help also with renovations of the bathroom,
Right.
that it's safe for them to use. That's as far as that went, unfortunately.
Right.
At least guiding them in the right direction of who to call to try to get this rectified so that, again, it doesn't happen again. Obviously, there's a little bit of education too. You know, I noticed there was carpets that were tripping hazards. The equipment really which caused the fall was that they were the suction cups that kind of suction onto the bathroom wall. That's
Right.
what he would use to get up, and that's what released it, or I guess disconnected, and made him fall back into the bathtub. So again, a little bit of education on my part. You know, my best poised for that. You know, I'm not well versed, let's just say, in fall prevention strategies, but it's something that I want to learn more about now.
Right. That's fantastic. That's good that you went the extra mile and did that. Not to, so pat yourself on the back. We in York Region, we have a program. It's called the Paramedic Referral Program. So for clients in your patient's situation, the 911 based paramedic can identifies patients that maybe are in need of. So for example, this person had the fall in the bathtub. You've touched on the programs through the province of Quebec that maybe will support some in-home accessibility devices or whatever. We can do a referral on this person's behalf. So we gather the information required. You know, you do like a little paragraph explanation, contact information of the patient and their spouse, and then you can send it off. And then like in Ontario, our provincial, you know, authority, whoever who helps in a similar way, will connect with the patient. So that way you're a little bit eliminating, like, for sure someone will call him.
Exactly.
Whereas you've now put the onus on him. He may or may not.
Yeah, you're gonna say maybe tomorrow, and then it just never happens, and then we get a call, and you know, God forbid that he actually injures himself this time.
Sure.
So yeah,
Sure.
I really hope, yeah, because especially there's no follow-up process either.
Right.
You know, so no, that's all super interesting. Any other programs that come to mind?
Well, you know, during the pandemic, we definitely did like I project led a COVID response. So testing and vaccinations for institutional settings, employees, employee families, and then like our team supported when they ran the mass vaccination clinics, you know, in community centers and stuff like that. We helped support and staff those. there's a referral program that they talked about. It's not just if, old people fall. It's also if you encounter a client who is having a mental health challenge or a substance abuse concern that they want help with. Um, there are,
Yeah,
yeah,
that's extremely important too, because I mean, I can remember a time, I won't say, where I was working, but
Saint Lazare.
not at Salazar. But yeah, a gentleman had come in, obviously he had a history of substance abuse, alcoholic, and he really wanted to do something about it. Obviously, he came through the ER, and unfortunately for him, he wasn't able to get the care that he needed.
Right.
And even though I still remember specifically seeing like even a specific protocol that was there on like the pre-made protocols in the ER for physicians to, how to handle somebody who's going into withdrawal. And unfortunately, he didn't receive the care that he needed, and he just couldn't take it anymore. And I remember him just leaving. And I still think about that to this day.
Right.
How, is there something I could have done different? Got him in the right direction. I mean, I did go advocate for him, bring even that paper. I remember saying, this is like the kind of the care plan that we're starting to initiate as soon as we get to the ER, but
Right.
it was done. So that's great that obviously you guys have programs.
Shame. And the programs aren't like, they're not run by Paramedic Services. It's a referral program. So we take in the referral, the patient's information, and then we will then filter that to the appropriate agency. So a lot have to do with,
fall through the nets, people.
yeah, we're trying to prevent that. Yeah, for sure. So like, agencies like that provide home care, agencies that provide mental health supports, agencies that provide, seniors transportation, things like sometimes people can't get to their medical appointments, right? Or I can't go grocery shopping, this kind of stuff. So
did you guys go and analyze kind of all the calls coming in through 901 and then make a kind of database decisions? For example, people calling 911 because they needed to get to, I don't know, they ran out of their prescription medication, for example, and that's why you guys decided to create kind of a program for elderly transportation, for example. Did you participate in any of that?
That's a good question. So we did expand the program. So years and years ago, we only referred to Ontario's like home care agency. And then in 2016, 2015, we expanded it. And I was part of the team that assisted with that. But it wasn't, believe it or not, it wasn't data driven, unfortunately. It was anecdotal. So we thought it'd be a good idea to incorporate mental health referral pathways. We thought it would be a good idea to implement palliative care pathways, that kind of thing. And we connected with the agencies, and they're getting use. Do you know what I mean? So it's not like it was these were safe bet decisions.
Of course.
They weren't data driven, but they were generally accepted as we will come across clients in these scenarios. So
for sure, which again, you just named all those, and obviously, yeah, we come across them every day. There's one you mentioned there, palliative care.
Yeah.
Do you have any palliative care programs? I know other provinces have that. Yeah. Sure.
So we do have a palliative care program that is so there's two angles. So one is a referral pathway. So you come across a client who is at home. They've been told by a doctor that they're palliative, but they don't have any resources or supports. So we can do a referral on their behalf, and they can connect with a palliative care team who could provide a holistic set of like, in-home supports, psychological supports for the caregivers, that kind of thing.
Anything really, or any kind of supportive care for the palliative patients?
Yeah. So then the second component is in York. We have a palliative care program that is pushed to all ambulance operating paramedics.
Okay.
So we basically have a symptom relief kit that is for these patients in an effort to keep them comfortable and keep them at home. If that's their goal of care, for example.
Basically, home, not have to go to a hospital. They can be in a foreign kind of environment, so they get to essentially care the last days at home as possible.
So we have some medication that we give for like hallucinations and that, oh, what's the term? Okay, the term escapes me at the moment. Hallucinations, that kind of mental distress. We have antiemetics for nausea, vomiting. We also have a morphine, should they, or hydromorph, should they require some additional pain relief, that kind of stuff. Yeah, and that's all paramedics can, both levels of care can provide that stuff. Yeah.
That's great. That's amazing, actually.
Yeah.
I also, so that's not necessarily prevention, but I noticed on the York Paramedic website, there was personal medical information kits. Was that something, was that a project that you were part of, or just, I'm curious to know more what that is, and
do you want to pause the recording for like 15 seconds?
Sure.
Can you do that?
Yeah,
sure.
So you got one right there?
Yeah, so the miracle of editing, I've now returned with a personal medical information or emergency medical information kit.
That's
so
great.
this is, I have a daughter, she's 3, and we have a lot of caregivers in the home. She's a healthy young lady, but I've got one of these. It's got a photocopy of her health card in it, and it's got like her allergies, her medical history, all that kind of stuff. So if someone is watching my kid, they can just, and something happens, they got to go to the hospital, they can just grab this kit, take it with them.
That's
and the same,
super visible.
Yeah, exactly. It's a magnetized. They just go in the fridge, and it's it's not intended for 3-year-olds, but I got a free one, so it's mostly intended for seniors and that kind of people with more complex medical issues. You can just snag this. It's all like organized, past medical history, their medications, their allergies, and all their demographic data. It's just to support paramedics in providing like a better continuity of care. Yeah.
Yeah, that's great. Perfect. Well, thank you for sharing that. That's great.
Yeah, you're welcome.
Any other projects that you can think of? Obviously, we've talked about a lot of different ones.
We talked a lot about that. I just want to maybe touch on one, at least one, that may be of interest to your paramedic candidates. So I talked about a wellness clinic that we do for seniors, but we also do a lot of home visit programs. One of them is called Seniors Home Support, and that is a service that where we're partnered with a family health team that consists of a pharmacist, a physician, nurse practitioner, chiropodists, all these different healthcare providers. And we care for a certain subset of seniors who are generally homebound. And so what the community paramedics do is provide episodic care in an effort to keep them out of the hospital. So for example, someone might be at home experiencing shortness of breath. That's not, it's not like urgent at the moment, but it may be escalating. So in this situation, a paramedic would attend, do an assessment, liaise with the general practitioner or the on-call physician, and devise a treatment plan to try and keep them in home. A lot of times that includes not necessarily us dispensing medication, but a prescription being written and us facilitating.
Exactly, and because you essentially identified potential, issue.
Let's say they've got a pneumonia forming or something like that. So they, instead of calling 911 and having paramedics attend and being transported to emerge and then sitting in emerge for several hours or whatever, which exposes them to a higher level of risk, right? Obviously, paramedics can go to the home, identify the pneumonia, and get some antibiotics prophylactically prescribed, like even without an X-ray or whatever. So, and then the other program that's just one example of some of the clients that we see, but the goal is to keep them out of emerge. And the other program we see, we work in emergency housing. So these are sites that are for folks experiencing homelessness. And again, we run clinic hours. These folks will come in with their Similar to when I was working in the north, they have very mundane medical issues, but because they are precariously housed, a lot of times they have mental health or addictions challenges. These small problems can escalate.
Okay.
So if folks are like sleeping rough, for example, this is what we call when they're sleeping outdoors in the winter,
Right.
just as an example. And they may have some frostbite, and if the frostbite's not treated, appropriately, it could spread, infection spread, sepsis, et cetera, et cetera. So,
Of course.
so paramedics will do their assessment, and in a similar model, they'll connect with a physician and get an order or a script written or some kind of treatment plan outlined.
That's really incredible. That's really exciting that that you guys are able to provide all of that care, preventative care. It's really, really incredible. And I really hope to be able to participate in stuff like that here one day in my home province. So that note, Rob, thank you so much for sharing all that with us today.
You're welcome.
We'll talk soon.
Okay, best of luck with everything.
Thanks.
Thanks all.